Centaur, spelled with an O, not an AU. And all the UAB people know my passion is the acid base and electrolytes. What's one of my passions? I have a lot of passions. The whole idea of this is to get better at interpreting labs. We certainly don't expect the discussants to know all the answers. There are plenty of attendings who don't know all the answers. What we hope is that everybody grows from week to week. I think that's happening, and people are coming back, so that's a good sign. We have a lot of followers. I was amazed. We've been doing this for like 5 weeks, and we have over 1,000 followers on Twitter already, which impressed me. And a lot of people are going to the YouTube page, so it's all good. So Anna, since this is your first clinical rotation, why don't you introduce yourself?
Okay, hey everybody, my name is Anna Predamescu. I'm a third-year medical student. Like Dr. Centaur said, this is my first clinical rotation, so I'm on IM right now. It's been great, and I'm excited to be here, and thank you all for having me.
Okay, and I think Nishah.
Hi guys, this is Nishah Panchani. I am currently an internal medicine intern at UAB, and I'm also really excited to be here.
Great. And maybe Stephen, you and the rest of the chiefs can introduce yourselves, and even the one and only Lindsay.
Sure. So I'm Stephen Alon. I'm one of the chiefs here at UAB. I'll be helping with the case presentation. And I just want to shout out to Anna and Nishah because this is a reunion for our VA team. We just wrapped up working a few weeks together. I'll let Sean and Seema and Lindsay introduce themselves.
Hey, I'm Sean. I'll be running the Miro board, so really the only time you should hear from me is if something goes wrong, and hopefully it won't. So, Seema?
Yeah, hey, I'm Seema Kumar, one of the chiefs as well from UAB. I'll moderate the chat, which is always on fire. I can't keep up with you guys, but I will do my best.
Hi everyone, I'm Lindsay Shipley. I'm a third-year resident, and I'm just here to hang out tonight and learn some great pearls from you guys.
All right, great. So we will jump right into our case. So the way it works, I'll give you a little background on HPI and then a BMP, and I'd love to hear your thoughts. So this is a 55-year-old gentleman. He is coming in to the emergency department with 3 months of progressive dyspnea and exertion. And he's got this BMP with a sodium of 141, K of 3.8, chloride 99, bicarb 31, BUN 10, creatinine 0.9, and a glucose of 103. So,
Anna's on the lukewarm seat.
All right. So Anna, why don't you give us your thoughts about when you hear a guy with several months of shortness of breath with that BMP, what kinds of things come to your mind?
Well, the first thing that pops into my mind is that some sort of pulmonary restrictive fibrosis process. I'm looking at the BMP as well. Well, the bicarb is really high, so we're at 31. So some sort of metabolic alkalosis. Let me think. So progressive dyspnea. I'm just trying.
Wait just a second. There is this random Persian that just signed in. He doesn't have any hair. I don't know what he's doing here. Never mind. I had to pick on Reza. Anna, you're doing great. So, what is the abnormality in the BMP? And you pointed it out.
So the elevated bicarb being 31.
Right. And what are the two possibilities for an elevated bicarb?
So metabolic alkalosis or respiratory acidosis with compensation.
Spot on. That is great. Would everybody please react with a clap there, because this is a brand new third-year student. That was really good. Is there anything else wrong here? So There's a calculation you should always do just to make sure it's okay.
Let me
The
think.
anion gap.
Yeah, so what's the anion gap?
Okay, so the anion.
This is cruel when you ask medical students to do math in their head.
I know. Well, it's sodium, so 141 minus, is it bicarb plus chloride?
That's correct.
99 plus 31. Y'all, math, come on. Let me see. 271.
It's 130.
Yeah, just kidding. Wow, can we scratch that?
So then the anion gap is
11.
11. And that should be a normal. The chat has asked for the albumin. Why did the chat ask for the albumin, Nishah?
Because you have to correct for it.
Right. So
Look at the albumin and correct for the gap.
yeah, the gap is mostly albumin. Now there's a complicated formula that you technically could use, which is 11 minus 2.5 times the difference in the albumin from 4. That's too hard to remember, and what we do is we just go ahead and multiply the albumin by 3, and that's close enough. It's always within 1 or 2. So we can ask for the albumin and see that. Now, it probably is important to figure out, is this a respiratory acidosis or a metabolic alkalosis? What's making us think about respiratory acidosis so much is progressive dyspnea on exertion. But until we get at least a venous blood gas, we wouldn't know. Now, in this patient, what would be the advantages of getting an arterial blood gas, Anna?
We could calculate the AA gradient if we had an arterial blood gas.
Exactly. So he has progressive dyspnea on exertion. An arterial blood gas is going to give us information about his oxygenation, which is going to be much more helpful than a VBG. The VBG is great for acid-base disorders alone, but we're just as worried about his oxygenation as anything else. Now we don't know what his O2 sat is, and there may be some other clues. There are other things that we could ask if we're just trying to figure out what his dyspnea on exertion is. But this is an exercise in getting the most that we can out of the numbers. So, Steve, what can you do for us?
You guys want an ABG, huh? So I'll give you one. The pH is 7.36. PCO2 is 55. PO2 is 76. And bicarb is 31, and that's on room air.
Okay, so this is clearly an intern question. So Nishah, you can ramble on about this. This is on room air.
My first thought about this is that he is acidotic. His CO2 is 55, which is high. And so I would say that, first off the bat, I would say that he has respiratory acidosis. And then his bicarb is elevated, so I'm assuming it's compensation for that. The O2, the partial pressure of oxygen seems a little low to be on, I mean, he's on room air, but it seems a little low.
Okay, so great job with the respiratory acidosis. Now, our medical students said something about an AA gradient. Do you think we can calculate an AA gradient? So it's more math.
I know, I remember this alveolar equation at some point. I think.
Okay, so this is actually this is a good thing to remember. How to do the AA gradient, and we've done this on previous episodes, but I don't think we can overdo it to remind people this. And the great thing is this is on room air.
Yeah.
So let's go through. So Nishah, it sounds like you would like a refresher on this. What about Anna? Do you remember how to calculate it?
I think I actually might, but maybe not. I know that I had Dr. Johnson for Pulm, and he talked about this so much. So
Yeah, he's great.
he's great. So okay, I think it also depends on like where you live. So
It does.
It'll change
It does a little bit. We're
Yeah.
you know we're a little bit up in you know, we're at about 800 feet above sea level, so there's a slight adjustment, but we'll make believe like we're at sea level just for the sake of argument.
We're using 713, you said, or 740?
Yeah, we'll use 713. So explain how you got to the 713 in case some of the listeners don't know.
So I think that's the partial pressure of oxygen, like the pressure in like where we are. So in Birmingham would be 713 of oxygen.
Well, so yeah, so the barometric pressure is about 760. As a matter of fact, it's I think I looked it up and it's around 750.
Minus 47 is the water in the air, I think.
That is great. And that's where we get the 713.
Yeah. So 713 multiplied by the percentage of oxygen in the air, which I think is 21% here. So it'd be like times 0.21. And then you subtract by PA, little a, arterial CO2, which you can get from your ABG. And then you divide by R, which is your respiratory quotient. It's the amount of CO2 produced divided by the amount of oxygen consumed. And it's usually we use 0.8.
Okay, so let's see if we can, Dr. Carter, sir, if you could, you actually have it here. So what you would normally do is pull up MedCalc or something like that and plug in the numbers because most people don't like to do math.
Yeah.
And this is not going to be a huge AA gradient.
Okay.
Somebody in the chat, I think, had calculated it. Can someone, the AA gradient is 5.
Okay.
The AA gradient's not 5. Let's see. It'd be 76 plus 1.25 times 56. A quarter of 56 is 14. 55 is 14, so that'd be 69, and 76 would be 140. Well, wow, AA gradient of 5. I don't believe the patient's on room air. That tells you there's something wrong with the numbers. Patient's not on room air. It's too small an AA gradient. So let's assume it's true. That means that the dyspnea and exertion is not due to the lungs.
Yeah.
So why do people get respiratory acidosis?
Could it be something else like outside of the lungs? Like if you have some sort of, extreme obesity, I would think if it's compressing your rib cage, you can't really breathe as well, maybe, or something.
Okay, so what are you getting at with that? That's a great thought.
That it's not something intrinsically wrong with the lungs themselves. Like the lungs are fine. There's an issue with the mechanics surrounding them, I suppose.
Right, and technically that's called what?
Oh gosh.
So let's go through some technical definitions. The patient has an elevated PCO2. What does that mean? This was actually on my internal medicine boards.
It's a respiratory acidosis?
No, it means the patient's hypoventilating.
Hypoventilating, okay.
I had this wonderful attending when I was a medical student many, many years ago, Orrin Murin. He was about 4'10". He had grown up in Turkey and escaped the army. He said he could never go back to Turkey. He had this wonderful accent. He was first an anesthesiologist and then a pulmonologist. And he used to say in a Turkish accent, PCO2, pure measure ventilation. So that's one take-home thing. Elevated PCO2 is hypoventilation. Decreased PCO2 is hyperventilation. It has nothing to do with the rate. So we know the patient's hypoventilating. Why do people hypoventilate? So what would be the classic, you were at the VA, Anna, what would be the classic patient who has a respiratory acidosis from hypoventilation?
Somebody with COPD.
Right. But this is not COPD because we don't have a large AA gradient.
Mm-hmm.
So Nishah, what is this?
So Anna did mention like mechanical issues, but I was
Right.
also thinking neurogenic causes like
Okay.
diaphragmatic paralysis. There are certain neuromuscular diseases like myasthenia or Parkinson's. I mean, a lot of these could cause a patient to be hypoventilating.
That is great. So what we have to figure out, is it mechanical or so it could be muscular, could be central, could be obstructive sleep apnea gives you respiratory acidosis. So we need to know what the patient looks like and what other complaints they have. So what we've learned so far is that the patient's hypoventilating, their lungs seem to be functioning well, but yet they're hypoventilating, and they're complaining of dyspnea and exertion.
Mm-hmm.
So that makes me wonder. I like the fact that you included neurological causes and you included especially muscular causes. Somebody in the chat had asked much earlier on what the BMI was, and so I think that we need to get more information from the wonderful Dr. Alon.
Yes, so I'm gonna fill in for Dr. Alon for a second and give a little
Okay.
extra information.
Did he have to go check his food? And how's the chicken going?
You know, it's doing its marinating magic. I'm just letting it be.
Okay, good.
So the BMI is 26.
Okay.
Okay, so how does that help us? Who did you want that, Nishah?
It was Anna.
Okay, I'll say we'll let Anna do it then.
Oh, that doesn't help me very much, I'd say, because I don't. Well, I think so. They're a little overweight.
He doesn't sound too big
But it
though.
doesn't sound big enough for what I would think would cause obesity hypoventilation situation.
That's downright slim in Alabama. 526. If you've walked around at all, so
Yeah, he's fine.
can you get obstructive sleep apnea with a normal weight?
Yes.
Sure.
Yeah, you still could. So we can't rule that out, but we really have to worry about those other things. So we have to go do a physical exam and understand more about this. Could it be, somebody said something about COP cachexia. You wouldn't have this small an AA gradient if it was COPD. So this is more pure hypoventilation. Maybe his dyspnea and exertion is he just can't breathe faster when he wants to get his oxygen up, because at 76 he's doing fine. His O2 sat's probably it's somewhere in the 90s, but he's going to run into trouble if he exercises and has to try to breathe harder, because this is as hard as he can breathe. We think that, so we have to just figure out what the cause is.
Mm-hmm.
Does that make sense?
Yeah.
So Nishah, you're the intern. Why don't you see whether or not we can convince Seema to give us more information?
Can we get past medical history?
Yeah. No, really no other past medical history.
Okay.
Ah.
How about medication?
So not on any meds.
Okay, well, any surgical history?
Nope.
Nope. Okay.
Not helping you much.
We may have to resort to a physical exam.
Let's just go to the physical exam. How does this physical exam look?
Well, we could ask, so here a review of systems might be really helpful.
Mm-hmm.
Yeah.
Yeah, so, and I can tell you that if you mentioned this in the chat as well. So no other pulmonary symptoms that this patient mentioned, and no other weakness.
Okay.
I see
Okay.
no illicit drug use. I see that's mentioned as well in the chat.
Mm.
Okay, so everybody's looking for, how can we explain this? And there's no weakness anywhere, right? Any B symptoms?
Nope.
Anna, do you know what B symptoms are?
Yes, fever,
Okay.
weight loss.
Yeah, so I just wanted to make sure that I wasn't using jargon that you didn't understand.
Not yet.
Okay.
Okay.
The chat keeps on popping up on my thing, and I'm watching and it says these guys are out of their minds today. they're having so much fun. I guess we better examine them.
Yeah, so, he's afebrile, his blood pressure is not elevated, his respiratory rate is 20, that lovely 20 that always pops up in the chart.
Does that tell, wait, this is really an important point. I don't know how many medical students are on, but I used to think that there was like a random number generator. Well, there was 20 plus or minus 2. Every time I see a respiratory rate of 20, which should be tachypnea, it ends up that I don't know where that number comes from. And that I've seen that in different parts of the country. When I visited other institutions, everybody sees different numbers. I guess some hospitals it's 16, some hospitals it's 18. So we're not really sure what to do with that. Continue, Seema.
Sure. So so we talked about his vitals. So his lungs are clear. He has normal strength in all of his extremities.
Okay.
So everything else looks fine.
Mm-hmm.
Somebody want to know about orthopnea, paroxysmal nocturnal dyspnea, things like that.
Yeah, so I'll jump back in. Thanks, Seema, for covering me while I tended to my marinating chicken. So no orthopnea, his JBP is about 1 centimeter above his clavicle at 30 degrees.
Okay.
Any leg swelling?
No leg swelling.
So ladies, what are we going to do? This poor guy has significant respiratory acidosis. He's very uncomfortable with progressive dyspnea exertion, and we can't find anything.
Maybe we should get more labs.
You want to get more labs? What labs do you want to get? And tell me why.
Possibly CBC.
Okay, so let's go through dyspnea exertion. So we're gonna forget about labs now. Let's just think of all the systems that could give us dyspnea exertion. So a CBC is great. How does CBC present with dyspnea exertion?
I'm not really thinking so. I guess my whole thing was if he's for some reason really anemic, he could be getting really fatigued as he's exerting himself, and that could be, I don't know. I think that's
I like the way you're thinking. So you're 100% right that anemia is in the differential of dyspnea exertion. If you have that, usually you're hyperventilating.
Mm-hmm.
And so we have to figure out what's confusing to me at this point is why is he hypoventilating? We don't have a good weight reason. We don't see any evidence of muscle problems. They don't describe him having severe scoliosis. And I had a psych attending who had to sleep on a respirator. He had severe scoliosis and had restrictive lung disease for that rate. So I think you would hyperventilate with anemia. Livy is asking that. I think you would to try to keep your oxygen up. I don't think you would hypoventilate, but I guess I could be wrong. But do we have a CBC?
We do. So his white count is 8, hemoglobin is 14.2, and his platelets are 257.
So I don't need to call Jory May up to know that that's normal.
Yeah.
So I know we're doing fine there. So what were the things that we talked about? We talked about muscle.
Mm-hmm.
We don't have any evidence of muscle problems.
Yeah.
We talked about obesity, hypoventilation. He's not obese. We talked about central. So how do we think about central hypoventilation?
Mm.
You have some central receptors in the brain that would control the rate you ventilate at. So that, like, similar to how obstructive sleep apnea presents.
So I think you're right. I think that there are that. This is one of my weaknesses, and I'm not embarrassed to say that. I would immediately be going to the books to remind myself of that, of what that's going. I think there is central hypoventilation, and I think we have to think about that as a significant issue. Let's just go back through. So when I see dyspnea, I think of pulmonary. We've looked at pulmonary really carefully. I guess we could still do pulmonary function studies and show that the vital capacity is down or something like that. And why is the vital capacity down would be the question. We might get a chest X-ray. Maybe the patient has pleural effusions, and we didn't do a good enough lung exam to find the pleural effusions. I'm not saying that all of our residents can't find pleural effusions, but after they've seen the chest X-ray, they're really good at finding the pleural effusions. But that would be a possibility, because anything that decreases the parenchymal size. So I think we'd need to have a chest X-ray. So the heart, we got nothing going for the heart, right?
Mm-hmm.
We don't have dyspneic exertion, we don't have JVP, we don't have peripheral edema, and we don't have RALs. Again, we'll look at the chest X-ray, and we don't have tachyarrhythmia or bradycardia.
I would also suggest getting a drug panel on him.
Okay.
See
and what drugs are you looking for?
anything that would depress his respiratory system, so like opioids specifically.
Right. And thank you for saying opioids and not the N word. So, that's worth checking out. Do we have a UDS, Stephen?
We do. Nothing.
Okay.
Nothing found.
Okay, but definitely a good thought. We have musculoskeletal reasons for dyspnea and exertion, but we looked at him and he doesn't seem to have scoliosis or something that musculoskeletal should do it. The number one cause of restrictive lung disease is obesity. He's got nothing going for that. And if he had any other restrictive lung disease, he should not have a normal AA gradient or a supernormal AA gradient. You get dyspnea and exertion if you have acidosis, a metabolic acidosis, but he doesn't have a metabolic acidosis. He has compensation for respiratory acidosis. So then I think that leaves us back at neurological, and people have suggested MRI. I guess we need to look at the brain, and we need to go to the books. This is where I go to the books and try to figure out what I'm looking for in the brain and how to figure it out, because I don't know.
Mm-hmm.
So just to help not clear any waters at all, so we got a chest X-ray that you guys asked for. Clear lung fields with poor inspiration, no cardiomegaly, no pleural effusions, no interstitial opacities. So
the poor inspiration is the clue here. Is why does he have poor inspiration? Just because we didn't find anything on neurological exam, could he still have decreased muscular strength, somewhere in the chest wall or the diaphragms, etc.
Mhm.
So I think we have to figure out is the problem in creating that negative pressure and being able to have a normal vital capacity, and that suggests that we have a decreased vital capacity. We could prove that by doing spirometry.
Mhm.
We could also look for central causes, and all of this because the bicarb is 31. So we've come a long way, but we're not sure where we're going next.
Mhm.
Yeah, so we weren't either. This was a challenging patient. And so I'll give you guys a little more history. I don't know if it'll give you the answer, but it'll move us along a little bit. So he did get PFTs, which showed a restrictive lung picture. His FVC and his TLC were about 60% of predicted. That prompted a high resolution CT, which showed no parenchymal abnormalities, no fibrosis. And so given the acidosis, the respiratory acidosis, we couldn't explain with clear lungs and restrictive lung picture, we actually consulted neuro, and that may help direct you guys a little more.
Great. So let's spend a minute going over, because we still have another 20 minutes, going over pulmonary function studies and how do you determine restrictive lung disease from pulmonary function studies?
So you really look at at least I look at the FVC, FEV1, total lung capacity, and residual volume. And so if it would be an obstructive cause, such as COPD or asthma, you would have elevated total lung capacity and residual volume because they're basically holding on. They're having issues with the actual expiration of that. They've lost a lot of the elastic recoil. And FVC to FEV1 is going to be decreased, so less than, I think it's 80%.
So this is I just have to interrupt. You've been on medicine for how many weeks?
4.
4 weeks. And she already knows to answer the question she knows the answer to, not the one that I asked.
Oh.
So she wanted to show me that she knew obstructive lung disease, and she's 100% right. But what defines restrictive lung disease?
So you have an FVC to FEV1 that's either normal or elevated.
Well, you can have both obstructive and restrictive lung disease. So you can have a decreased FEV1 to FVC, have obstructive lung disease, but also have restrictive lung disease. And how would you know that you had restrictive lung disease?
With the, I guess, I don't know, residual volume, would it be decreased?
Learning is about to occur. Nishah, do you know?
Can you repeat the question again? I'm sorry.
Yeah, what one thing on the pulmonary function studies defines this as a restrictive lung disease? This is a classic question that I'd say brand new interns, way less than 50% get right.
The total lung capacity would be decreased.
You are in the upper 50%. So Anna, that's where you look. The total lung capacity being down means, by definition, that's restrictive lung disease. So how do you work up restrictive lung disease? Well, first you look for obesity because it's the most common cause in the United States for restrictive lung disease. And the radiologists at the VA that I talked to who are really good with this type of stuff said, if someone has a BMI of 35, 40, and they have restrictive lung disease, don't bother to get a high-res CT.
Mm-hmm.
You're just giving them radiation. But this patient, it was appropriate because he's not markedly obese. He's slightly overweight, technically.
Mhm.
So we're still back at a restrictive lung disease, which is exactly where we were before. That's what we were assuming because he's hypoventilating, and neurologically, and that's the chat has gone sort of crazy here. So Seema, why don't you help us with what the chat is thinking and what they want to do? Is Seema checking the marination again?
No, I'm here. Yeah, so I see we do have a lot of mentioning about the same points that you brought up about the TLC. I did see someone mention doing an LP, which we could talk about. And I've seen a lot of people wanting to investigate the diaphragm a little further as well.
Okay, so they called neurology. So I guess the diaphragm could be a neurological problem, and they did have a couple of guesses at eponyms. Rob Weber wants a protein gap. Why does he want a protein gap? We could get one. I don't know. Sniff test. Tell me about the sniff test.
Is it, this is what I think it is. Okay, I'm not 100% sure. Is it work?
Yeah, I'm not very sure either. We're going to probably have to get someone else to explain it.
I thought it was the test where you're looking at if the diaphragm is like contracting when you sniff, and it's used to look at like hemidiaphragm paralysis often.
Right. So the question is
that called the sniff test?
Why? Right. Well, why would this guy have a bilateral or even unilateral diaphragm problem? Now, they said there was decreased volume, and they didn't say one side or the other. So I guess you could go down with fluoroscopy and see whether or not you can figure this out. Well, why would we do a spinal tap? What are we looking for in a spinal tap?
Myasthenia gravis, oligoclonal bands.
Yeah, so we got this is the only thing we have going for myasthenia, right?
Mm-hmm.
Because we don't have any eye findings, et cetera, et cetera.
Mm-hmm. So,
well, I don't mind doing it. I'm just not. I'm trying to figure out what diagnosis we're trying to figure out. So I want to know what neurology thinks is the best workup, because I don't know.
Yeah, no, we were wondering too. And so, like the chat had pointed out, and like you guys had pointed out, we were wondering about the diaphragm, especially with the poor inspiratory effort and the restrictive pattern on the PFTs. So they actually recommended as a next step doing a diaphragmatic EMG, which I had never heard of before.
Diaphragmatic EMG. Mm-hmm. I love it.
Which only done at specialized centers, not done at most places. And so what they found was weak action potentials that in their mind reflected muscle weakness in bilateral diaphragms. And they followed that up with a phrenic nerve stimulation, which measures the propagation of the electrical signal in the phrenic nerve to the muscle, and that was preserved with normal amplitude. So they recommended that he had bilateral diaphragmatic paralysis.
Now, what causes that?
Yeah, so ultimately he was actually diagnosed with ALS. And the way that happened is initially we weren't sure. We were wondering about myasthenia and so forth. But over the next couple of months, he actually developed a right foot drop and then weakness in his bilateral upper extremities. And so on review, it looks like about 1% of cases of ALS present with isolated respiratory muscle weakness, which I thought was fascinating. Really unfortunate, but really interesting. And so his ultimate diagnosis was ALS.
In the short run, are there diaphragmatic pacemakers to help them breathe better?
There are diaphragmatic pacemakers. given his clinical course, he actually progressed quite quickly. He ended up ventilator dependent within a few weeks of presentation.
It's a really sad case, a lot of good learning points. Let's spend a little time going through the learning points. So let's start out with Nishah. Give me two things that we went over today that's going to help you the most. And the chats, Seema will be looking at the chat. Please feel free to put down the teaching points that you think are most important so that Seema can summarize those afterwards.
I think for me, that was really interesting in that they got a diaphragmatic EMG. We had a patient a few weeks ago where we were considering a sniff test on. He had, I believe he had Parkinson's disease. I'm not sure, I've kind of forgot. But that is really interesting that we have something like that available to use.
Okay. So that's one thing. Give me another thing.
The AA gradient calculation.
Okay, and Anna?
So for me, isn't so much the calculation, it's more like to remember to calculate it, to think about like intrinsic things that are going on actually with the lungs versus something that could be causing a restrictive outside of the lungs. And then from there, thinking about muscular versus neurological versus just obesity, just having that categorized in my brain, kind of a nice little dichotomy there.
Seema?
Yeah, so we covered a lot today. And so kind of starting out, you know, we saw the elevated bicarb and we talked about the two branch points being thinking about metabolic alkalosis or compensation for respiratory acidosis. As Anna mentioned, we delved right back into that AA gradient, which we will, you can peep the picture on the Twitter if we all need a refresher on how to calculate that. As we were talking about this patient's symptoms, we discussed the dyspnea pyramid and thinking about the various causes kind of working out to in for dyspnea. And then we really went into the PFTs, which is great because those are always really tricky to interpret. So we now all know that the one finding that will tell us if there's a restrictive lung disease problem is a total lung capacity. And the number one cause of restrictive lung disease is obesity. So that's kind of where we can start our investigative process. And most importantly, let's just think about all the learning that just happened because of one pesky bicarb. It's amazing.
It's always the BMP. The BMP is so great. Okay, thanks everyone for joining us today. And I hope everybody learned a lot. If anybody has any questions, I'm not going anywhere for a few minutes, and if there are any questions in the chat, we're more than happy to answer them. But otherwise, have a great week, and may your hospitals have decreasing numbers of COVID patients every day.
Thank you so much. I really appreciate it.
Great job, Anna and Nishah. Can we have a round of applause for Anna and Nishah?
Wow, thanks.
Great having y'all in the chat box.
We got claps in the chat box. Thank yous. ICUs are full. Well, we're hoping that your ICU is less full in the near future.
See you guys next week.